Thank you, and I'd like to thank everyone for joining us this morning. I hope this is all very interesting and educational. So one of the things I think that's revolutionizing the treatment of CLL is going to be the advent of the tyrosine kinase inhibitors. And while I'm specifically speaking to CLL, these tyrosine kinase inhibitors seem to have a broad array of activity against all low-grade lymphomas. One of the things that's important to remember, and something that we're going to be hearing a lot about in the future, is that it does seem that these agents don't work against aggressive disease. And that's still an issue of debate with which a lot of data are currently being generated. And the answer may depend upon us figuring out how to use them properly. But for the time being, not so common, fortunately, but also very unfortunate for the patient, scenario is one where the patient has a dramatic response to their tyrosine kinase inhibitor with a massive reduction in their CLL, greater than 95%. And lo and behold, about 4 to 8 weeks later, they develop a rapidly expanding lymph node, which is a Richter's transformation. This represents sort of our next step in what we sort of need to conquer. One of the important questions, which I think is going to come out over time, is whether or not these Richters are truly most likely the result of just time that the patients had the CLL, which is supported by a lot of the current data involving the use of chemotherapy agents. And of course, the number of treatments does correspond often to the duration of therapy, duration of CLL. And two, whether or not, with the advent of these new agents and the lack of chemotherapy and its DNA damaging effects, whether or not we'll truly see a drop in the Richter syndromes. So speaking to CLL right now, the B-cell receptor has actually become a surprisingly high-yield target for looking at therapeutic options. One of the things that had always intrigued me is that CLL cells are anergic cells. And so by definition, their B-cell receptor is sort of turned off, or at least turned down, depending upon how you look at it. And so while it seems like CLL cells are not highly utilizing their B-cell receptor, these kinases have proved to be very effective therapies. One of the things I think is very, very important to keep in mind, and I'll discuss this in some future slides, is the fact that while we call these B-cell receptor antagonists, they really have effects everywhere in the cell. And these effects are really much more than the B-cell receptor, but also include many other receptors involved in survival and homing and all different aspects of CLL survival. So the ones that we have so far that have proven to be effective targets, I'm going to go through them. One includes SYK, which is short for spleen tyrosine kinase, and two agents that we currently have in clinical development. There are many others. This is a very short list by nature. The first one was a drug developed by Rigel, which is subsequently being developed by AstraZeneca, R406. The other one, a Portolia compound, PRT06207, is about to enter clinical trials in CLL. What I'd like to point out is that we do have some data with R406, which is also phosphatimab, in earlier trials in CLL and currently in inflammatory diseases such as rheumatoid arthritis. The next target is BTK, Bruton's tyrosine kinase, and this is an interesting kinase because its importance was discovered with groups of children, about 30 worldwide, who have no B cells because of a genetic deficiency in BTK. One of the important things that's interesting is that the parents seem to have low levels of BTK, but sufficient activity to have absolutely normal phenotype. So what it looks like is that you need about 85% inhibition of your BTK enzyme before you start manifesting the phenotype of B-cell depletion. And that's an important thing to keep in mind going forward when we start talking about the efficacy of these different tyrosine kinase inhibitors. So with BTK, we have 3 that are currently entering clinical trials. Ibrutinib, CC292, which was formerly AVL292, which is now owned by Celgene, and ACP196, which is from a company called Acerta. And then the third, PI3 kinase, which with no data, but just out of a gestalt, I sort of believe is one that has far more reaching implications throughout the cell. And the PI3 kinase, we have two agents that are very far along in their clinical development. One is idelalisib, formerly known as GS1101, formerly known as CAL101, and IPI145. So you can see here how these agents really are, you can see here how these agents really fit very nicely into the B-cell receptor pathway. But what I want to emphasize is this really is what the tyrosine kinase signaling pathways look like in CLL. And you can really see that anyone who shows you anything more simple than this is really just deluding themselves. And so I do want people to keep that in mind. So once again, here's the list of the agents that are moving along through the clinic. And I just want to point out that fostamatinib is the one furthest along in terms of its duration of being worked with, but is certainly not as close to approval as ibrutinib and idelalisib. So what are these issues with these different agents that we need to look at as clinicians? One is going to be, how are our current response criteria relevant to these agents? And do we need to make adjustments because of these agents? The second is the dosing. And the third is going to be, what are the differences between these agents? So speaking first to the response criteria, all these agents working through either the B-cell receptor or through some other adhesion molecule pathway demonstrates a very marked lymphocytosis, with lymphocyte counts getting as high as 800,000. And I'd like to point out that we actually have not seen in any CLL patients on the clinical trials any negative sequelae of this lymphocytosis, even ones that high. My own personal best was 762,000, and that patient absolutely was fine. But we see this marked lymphocytosis associated with a very rapid reduction in lymphadenopathy. And the first time point where the lymphadenopathy was really addressed was at cycle 2, which is why we see the line go straight down to there. But the lymphadenopathy is markedly decreased really immediately. And the lymphocytosis also occurs immediately. And while this certainly is evidence of a compartmental shift, and certainly probably not a one-to-one shift, so that the patients have far more cells in the lymph nodes than in the peripheral blood, and even if you were to collect all the cells that make it into the blood, it probably still represents a very small proportion of the total number of cells. But the big issue is that all these patients meet the definition for progressive disease in our clinical trials. So all of a sudden, we have a response rate of 0. But yet, when you look out here at month 12, all of a sudden people are nearly in CRs. And so then we have a real problem with our response criteria. As an anecdote, the very first patient treated on the phase 1 idelalisib trial was actually taken off for progressive disease. So the reason why we have response criteria is that we need to somehow measure the treatment efficacy. But clearly when someone who gets FCR and has a massive reduction in white count and a massive reduction in lymphadenopathy, it's clear that they're responding. With these novel agents, the question becomes, what happens when they have a massive reduction in lymphadenopathy and a marked increase in white count? So for the novel agents, our current criteria don't work, at least in the short term. And a lot of these patients do over time meet formal criteria for having a response. And even what we've seen, and we'll see data to this later on, the response rates will evolve over time. Not because patients are getting more and more therapy, but because as the lymphocyte count falls down and patients cross the threshold of a 50% reduction, they all of a sudden go in from being progressive disease to stable disease to partial responders. So we do need new criteria. Additionally, when you talk about the IMiDs, we see really not just a lymphocytosis, but we see often an anemia, thrombocytopenia, neutropenia, as well as big swollen tender lymph nodes. So I do want to, differentiate the differences between tumor flare and the lymphocytosis we see with these novel BCR antagonists. Tumor flares often do herald response, but they are very much uncomfortable. Let me just say it as that. They really, have an impact on the patient's well-being, and the patient feels lousy. Getting patients through the tumor flare has really been the object of a lot of clinical trials, with people combining lenalidomide with Rituxan, or people combining lenalidomide, thalidomide, and rituximab, or people using steroids and the IMiDs themselves. But with the BCR antagonists, patients actually feel better immediately. So this lymphocytosis is not a tumor flare, and that's a very important distinction. But we also need to know, with these clinical criteria, as to who to continue on treatment and who to stop. And so knowing the actual response early on is also important too, because we wouldn't want to continue to expose someone to additional therapy that's unnecessary. So in 2011, the Lymphoma Research Foundation sponsored a committee to look at the criteria. Chaired by Bruce Cheson and published in JCO in 2012, the committee made several recommendations. One, for IMiD compounds, it's important that the assessment of progressive disease should use repeat observations at multiple time intervals, so that if someone does have tumor flare, that you have the ability to see that resolution over time. Two is that when you look at progressive disease, you should incorporate characteristics that are not part of the tumor flare. For B-cell receptor targeted agents, the lymphocytosis alone should not count as progressive disease. And this is actually has a caveat where we say that in absolute, but we really don't understand what it means if someone has a lymphocytosis develop at month 6. If this is a patient who got rituximab plus one of the BCR antagonists, and the rituximab is cleared from the serum and the lymphocytes start to climb, that's not going to be evidence of progressive disease. So for the clinical trials we currently have ongoing, we don't consider the lymphocytosis as progressive disease, but yet in some patients who develop resistance to these agents, we see a rise in the white count often heralds the return of the clone. So it's also important to demonstrate other symptoms that might be evidence of disease progression. So talking about the dosing, we no more have a MTD, and this is very, very important. When we started looking at these agents, it all of a sudden became very clear that we were getting full inhibition of these kinases long before we got an MTD. So the dosing of these agents became a little bit random, and one allowed us to do fixed dosing because one is, it has a very wide therapeutic window, so we didn't worry about overdosing people. But two, because we just needed to have everyone over a threshold, it was easy to sort of pick a fixed dose that would sort of cover that for everyone between the weights of 40 and 120 kilograms. So we went ahead with fixed doses, but the other caveat to all this is also the idea of a threshold dose. And what you can see here is that when we look at the idelalisib phase 1 study, which started off at 50 milligrams once daily and went all the way up to 350 milligrams twice daily, we see that there is a significant difference in response between the 100 milligram BID and the 150 milligram BID above and below. And so clearly there is a threshold effect, and we actually look and see that the enzyme is not fully inhibited at 100 milligrams BID in all participants. But it's important to remember that the MTD was not reached, but we certainly stopped the trial at 350 because we certainly were seeing uniform responses as well as full inhibition of the enzyme. So in terms of dosing, MTD is no longer relevant, and dosing per body weight also is less relevant. But then what are the differences between all these agents? And this is something that we just don't know. Right now we don't have a huge array of different agents to compare. We can certainly compare Ibrutinib to CC292 or idelalisib to IPI 145, but we do not have equivalent data for a lot of these agents. Just as an example, I want to show you what Ibrutinib looked like in vitro when everything first started. So remember, Ibrutinib was originally called PCI 32765, and what you can see here is that it very nicely inhibits BTK with an IC50 of 46 nanomolar. But if you look at some other enzymes that are targeted at about the same level, there's BLK and there's BMX, which turn out to possibly be very important. So one of the questions is whereas BTK inhibitor like Ibrutinib inhibits BTK very effectively, what else is it inhibiting? So as it turns out, CC292 targets BTK very effectively, but it actually has a little bit of it doesn't target BMX and BLK. So whether or not these off-target effects, which are potentially very therapeutic or not, play a role, is some of the things that really can only be determined by clinical data. And so that's why we should never think of all these agents as the same. So speaking specifically to BTK inhibition, and you can see in this very neat flow diagram where BTK fits in, and of course remember how unrealistic this is. We have an inhibitor of BTK now called Ibrutinib. One of the things that's important about Ibrutinib is that it forms an irreversible bond with cysteine 481, and this will be important to keep in mind in the coming years when we hear about various aspects of resistance and ways to maximize its use. I'd like to point out that Ibrutinib has a two-phase clearance, with the first phase being relatively quick. And so you probably get below enough drug to have 80% inhibition by about 4 hours after dosing. And the reason why the drug actually is so effective is because of this irreversible bond. Dasatinib inhibits BTK at a level about the same as Ibrutinib does, but its bond is reversible. And so as a result, you need, instead of a once daily dosing, and its half-life is longer and it doesn't have the two-order kinetic clearance that Ibrutinib has, but you certainly would need continuous exposure over 24 hours, sufficient to block BTK if you were going to get a similar effect on BTK because of its reversible nature. So that irreversible nature is an important characteristic of Ibrutinib. So it's being studied at multiple doses, and as I mentioned, the dosing is somewhat arbitrary. So for CLL, the dosing is 420 milligrams. We did test 840 milligrams in CLL patients as well and didn't see a difference. But for mantle cell lymphoma, the dose is 560. And the reason for that is absolutely arbitrary. So this is the phase 2 study, 1102, which was recently reported, at least in part, in the New England Journal by Bird et al., really looking at CLL patients with the 420 and 840 milligram doses. It also looked at treatment-naive patients, 420 and 840 milligram dosing as well, with the 840 dosing in treatment-naive patients being stopped because there was really no difference seen in the relapse refractory patients. And what I really want to point out here is that these patients were heavily treated and they really were high risk. So for the relapse refractory, you can see that over a third have deletion 17p and a third had deletion 11q. And looking at the patient disposition, this is a very, very important slide which Susan O'Brien's going to speak to later. But I just want to point out that the reasons for treatment discontinuation, very few AEs, with really disease progression consisting mostly of Richter's syndrome as the cause. But in looking at the data, that we're going to have to wait for, because I didn't want to steal Susan's complete talk. My animation didn't work. It was really much prettier last night. So the pivotal study that Ibrutinib went forward with, which has been completed and submitted to the FDA, and we should certainly be hearing from the FDA any month now, was a comparison between ofatumumab and Ibrutinib. And the ofatumumab was dosed in standard format of 300 milligrams week 1, followed by 2,000 milligrams weekly times 7 additional weeks, followed by monthly dosing of 2,000 milligrams for a total of 24 weeks of dosing, versus Ibrutinib at 420 milligrams daily. The primary endpoint was progression-free survival, and while the trial was originally written without a crossover, once the primary endpoint of progression-free survival differences was met, patients are now being allowed to cross over from the ofatumumab arm into the Ibrutinib arm. And so that's actually happening right now at the participating institutions. Second pathway I want to talk about in my highly artificial slide is PI3 kinase, which really is at the center of a lot of different pathways, as I mentioned. involving, you can see here, CD40, B-cell receptor, IL-6, BAFF, and CXCR4 and 5. And I think a lot of the important effects that we're going to be talking about in the coming years are going to be mediated by the impact on the CXCR4 and 5 pathway. So one of the important things when looking at PI3 kinase is that PI3 kinase is a key enzyme in all cells in the body, and it's a key enzyme in all cancers. So one would think that we would be in great shape given what we've developed in CLL and being able to basically use it in any disease. The problem is that there are different isoforms in each cell. And this is sort of a key to the puzzle that really worked out very nicely in the favor of someone who takes care of CLL patients. So there are 4 different isoenzymes involving the P110 subunit of the PI3 kinase enzyme. Alpha and beta are very broadly expressed, and their knockout phenotype is actually lethal. And these seem to be the important isoforms present in solid tumors. And what of course happens is when you start targeting those enzymes and start inhibiting the PI3 kinase in those cells, you start seeing a lot of toxicities. With delta and gamma, it's much more forgiving to inhibit those kinases. And as you can see that they primarily exist in leukocytes, and the malignant lymphocytic diseases, actually the low-grade ones, so once again really the lymphomas, really seem to be very dependent upon the delta and gamma isoforms for their existence. So this really demonstrates a sort of an area where we can safely target the enzyme. And as you can see here with idelalisib specifically, the IC50 very much favors targeting just the delta isoform over the others. So the phase 1 study of idelalisib in patients with hematologic malignancies really just covered a broad landscape with CLL, indolent NHL, mantle cell, DLBCL, myeloma, and AML. And there is great preclinical data supporting the use of idelalisib in myeloma and in AML. Of course, as one could imagine, since the drug is really only going forward in indolent lymphomas, mantle cell lymphoma, and CLL, the large cell data, the myeloma data, and the AML data was certainly not good. So when looking at the overall response with idelalisib at 150 milligrams BID, these are data from Dr. Brown, the patients looking at the CLL patients overall treated at the phase 2 dose of 150 milligrams, you could see a very nice nodal response and then an overall response looking at what we call the PR with lymphocytosis, who are these patients who develop a 50% reduction in lymph node with an increase in lymphocytes, and then a formal PR by IWCLL criteria. And once again, with idelalisib, you see a very nice increase in lymphocytosis, which sort of heralds the efficacy, as well as a very marked reduction in the lymphadenopathy. And looking at the waterfall plot for idelalisib, you could see that almost everyone has some tumor reduction. Here, of course, is the 50% marker that we use for demonstrating a partial response. What I'd also like to point out are these hatch marks here, which are the 17p deleted patients. So very good efficacy in almost everyone, with very good efficacy in the very refractory high-risk subtypes. But in addition to the baseline improvement, in addition to the improvement in lymphadenopathy, we also see improvements in the cytopenias. And this is very, very important as well. So it's not just working on the lymph nodes, but it does work in the bone marrow. And in looking at the overall survival and progression-free survival, and these curves are, of course, continually being updated, you can see a 50% a median progression-free survival of about 17 months, with an overall survival not being reached. And I just want to highlight the adverse events that we see with idelalisib. The most common feature is going to be a transaminitis, which very characteristically occurs between weeks 4 and 8. And it's actually very impressive how the first time a patient gets exposed, if they develop the transaminitis, it's at between weeks 4 and 8. If you then hold the drug and re-expose them later on at the same dose, and they redevelop the transaminitis, it's immediate. really suggesting a memory to the idelalisib. So it's a very intriguing effect. Fortunately, this really occurs in a very small number of patients and actually only requires stopping the drug in about 10%. In some cases, we've been able to start the drug off at 50 milligrams BID and titrate up the dose over a long period of time, approximately 12 weeks, and avoid having a recurrence of the transaminitis. The other issue, of course, is the diarrhea, which interestingly, and what's important to remember, occurs late in patients who are relapse refractory, approximately month 18 to 24, but can occur early in patients who are less heavily treated. And we've also looked at idelalisib with a lot of different agents. You can see here rituximab, bendamustine, and bendamustine plus rituximab, generating very nice lymph nodal responses as well as overall responses. And of course, when you add a second agent like bendamustine or rituxan, that's going to clear the peripheral blood. The differences between the formal IWCLL response and the nodal response really goes away because all of a sudden we don't have the progressive lymphocytosis anymore. But I really do want to emphasize that, as seen from the earlier slide, the lymphocytosis resolves on its own and really doesn't herald any problem. So a lot of the reasons why these combination studies were done were purely to prove that the drug can be safely combined with other agents, but it also does demonstrate very nice response curves. So we're not looking at an overall response rate for idelalisib of about 25%, which is what it was actually in the original phase 2 data. So the pivotal study for idelalisib, which is actually, as of last Friday, formally closed because the treatment arm, the experimental arm, met its efficacy endpoint at the first data monitoring committee meeting, involved idelalisib at 150 milligrams twice daily plus rituxan at a slightly different schedule, 375 milligrams week 1, followed by 500 milligrams every other week through week 8, and then every 4 weeks through week 20, versus just Rituxan alone at the same schedule. And patients, once again, progression-free survival was the primary endpoint, with patients being able to cross over into what was called the 117 study. And this was double-blinded, so investigator and patient didn't know what they were receiving. And when patients progressed, everyone just got study drug. So patients on 150 milligrams twice daily of idelalisib were then treated with 300 milligrams twice daily of idelalisib with the idea of testing whether or not double dosing can overcome progressive disease in patients on idelalisib. And patients who were on placebo crossed over and actually got study drug at 150 milligrams twice daily. For various reasons, with the 116 being terminated as of November 8th, and all the patients on placebo will be crossed over onto treatment dose, they're going to sort of do away with the 117 trial as it now stands. So we'll not get the answer as to whether or not double the dosing can overcome drug resistance from this trial. And then I do want to talk a little bit about IPI 145, which, as I mentioned earlier, is a potent inhibitor of the delta and gamma isoform. And you can see here in its assays that it inhibits biochemically 25 picomolar and 243 picomolar delta and gamma. So its delta inhibition is as good as idelalisib with a much better inhibition of gamma. And what you can see here is at 25 milligrams twice daily, we get complete inhibition of the PI3 kinase enzyme. We do get higher levels from the 75 milligrams BID, but once again, the enzyme is fully inhibited. So this speaks to the fact that MTD became very irrelevant, and the dosing going forward is really going to be based upon the molecular targeting of the drug. And you can see the two lines here are for PI3 kinase gamma isoform and delta isoform. So looking at the preliminary data, looking at overall population, we see 19 patients out of 22 have a nodal partial response or a partial response, and only 3 patients not respond. So clearly this drug is also highly effective and active and will have a role to play going forward. And you can see when you go up to the 75 milligrams BID, though of course the numbers are too small to make any real formal comparisons, once again, 2 out of 3 patients responded. And I thank you.